Welcome to PwC's Next in Health, where we unpack the policies transforming healthcare and break them down to what it really means for the industry. Today's episode is focused on a major new law that's already changing the game, the One Big Beautiful Bill Act, or OBBBA. Signed into law on July 4th, the OBBBA is a sweeping reconciliation bill that marks a defining moment in U.S. healthcare and federal spending. Is it headline provisions, making President Trump's signature tax cuts from his first term permanent? But to make the math work, Congress needed to offset those costs, and they did it by zeroing in on healthcare. The bill itself is massive, almost 1,000 pages, and nearly 300 of those deal directly with healthcare. And while it's dense, the impact is clear. The legislation reshapes who gets covered, how care is paid, and how states, providers, payers, pharma, and patients interact with the system. Joining me today are three of my esteemed colleagues: Nichole Montgomery, who's going to talk about what it means for payers; Shannon O'Shea to talk about providers; and Phil Sclafani to talk about what it means for our pharmaceutical and life science companies. Let's dive in. Nichole, maybe we can talk about payers and what does OBBBA mean for them?
Thanks, Glenn. If I break down the three major areas where this bill will directly or indirectly hit payers the hardest, it is coverage loss and member churn, funding cuts, and increased administrative burden. To start with coverage loss and member churn, the CBO estimates 11.8 to 13.7 million people will lose Medicaid and Marketplace coverage in the next decade. This will be driven by new work requirements, more frequent eligibility checks, stricter immigration rules, reduced ACA enrollment periods, new copays, and skyrocketing marketplace premiums as the advanced premium tax credit subsidies expire. For many members outside of these cost increases, a big challenge is going to be navigating the complex verification processes, causing confusion, gaps in coverage, or complete enrollment loss. All of these factors in action will likely prompt healthier individuals to leave the market and drive instability in insurance risk pools, leaving payers who participate in these public programs with a sicker, higher need pool of enrollees. Secondly is funding cuts. As Glenn mentioned, states are facing a staggering $1 trillion reduction in Medicaid and federal funding over the next 10 years, and states are going to have to balance their budgets to make up for that funding reduction, which could be done through things like cutting optional Medicaid services like behavioral health, dental care, or prescription drugs, slashing eligibility for certain populations completely, cutting funding from other programs like education, or even lowering capitation rates to payers. Payers with large Medicaid populations will feel the strain from things such as more complex care coordination with these benefit carve-outs, immediate membership loss in their programs, and the need for tighter cost management. Providers, especially in rural areas, will also be hit hard from a funding perspective, which Shannon will go into shortly. But this could lead to potential hospital shutdowns and service cuts, creating healthcare deserts for payers to navigate from a network adequacy perspective. And additionally, kind of for the providers that are able to survive these funding cuts, they may push for higher Medicaid rates, adding further financial pressure on these payers. And then lastly, increased administrative burden. While states are on the hook for implementing these changes, payers are going to face quite a large operational burden, whether it's constant membership reconciliation, better data exchange required with state systems, additional staff to proactively support members with these new requirements. There will be an administrative lift, and some states may even offload some of these ongoing responsibilities directly onto payers through their managed care contracts, adding kind of even more to the load.
Thanks, Nichole. I think it's pretty interesting impact on the payers. Shannon, if you think about providers, what are we going to see?
It's a great question, Glenn. For providers, the most immediate impact is going to be a sharp increase in uncompensated care. And there are really two drivers to that. More people losing Medicaid because of the new eligibility rules and the phase out of DSH payments after September 2025. This is going to come up in very real ways. Providers will start seeing more patients who either can't pay or don't realize they've lost their coverage. At the same time, hospitals are going to see an increase in administrative complexity. Frontline teams may be the first to discover when a patient's no longer eligible for coverage, which is going to cause delays, denials, and confusion. This could represent, though, an opportunity for organizations to explore technology solutions and consider outsourcing specific functions to AI. High-resource systems may be able to cost shift, raising prices for the commercial payers or pivot to wealthier geographies. But unfortunately, the safety net hospitals and rural providers, those are the ones that usually really can't shift their strategy and will be most exposed. The bill aims to protect rural hospitals from some of the impacts of reduced Medicaid funding. What's called the Rural Health Transformation Program was set up, and it will award $50 billion in grants to states between fiscal year 2026 and 2030. And this is supposed to help support rural healthcare services. While the funding is unlikely to offset the new budget constraints, it at least could help to stabilize the rural hospital operations and prevent closures for longer that Nichole mentioned.
Phil, maybe you can talk about a little bit impact on PLS and maybe there's some bright spots here.
Yeah, sounds good, Glenn. And let's maybe start off with some of the good news. So the orphan drug fix that was contained at OB3 is definitely one that Pharma has long sought. As a reminder, that's currently drugs that have a single orphan drug indication were exempt from in a MFP negotiation under the Inflation Reduction Act. But as soon as you had multiple orphan conditions, you were no longer exempt. That sort of patch is now in OB3 to say drugs that have multiple orphan drug indications will be exempt. Definitely something Pharma's long sought and will help development and bringing therapies to market in rare diseases and other things like that. I think important to keep in mind, this kind of just reshuffles the list. So if one manufacturer's product comes out from the negotiation list, another one slots up earlier. So there'll be some give and take in there, but often positive for what the industry was looking for there. There also were some tax incentives for domestic manufacturing, definitely nice for those to be there. Fits well with kind of the broader tariff and onshoring issue we've been seeing. So maybe another reason or push to help companies bring back more of the drug supply chain, as the administration and others have been looking for. The negative side of things really goes back to some of the coverage losses that Nichole mentioned, right? So less insured lives under Medicaid and the ACA exchange plans, probably the biggest direct impact for Pharma. So we expect fewer prescriptions from those channels ultimately will mean less revenue, probably disproportionately impacting some companies that have products that heavily treat Medicaid populations and CNS, depression, others like that, and probably also hitting some high cost or specialty drugs the hardest. Beyond that, we're looking out for kind of the ripple effects. So maybe an expected rise in copay support or patient assistance programs that Pharma offers as there are more uninsured patients. We'll also be looking to see if payers or providers might turn to Pharma to provide greater discounts or other value to compensate for some of the losses that both Nichole and Shannon mentioned. And they're probably the most important for both patients and Pharma is just to look out for any of the patient disruptions that might happen, right? As patients go on and off Medicaid, or maybe their rural hospital goes out of business, obviously that impacts Pharma, who really want their patients to be stable on therapy and be able to continue long-term without disruption.
Thanks, Phil. It's kind of interesting hearing all the differences between the payers and providers and the impact. And I think as we dig deeper now, can we just talk a little bit about, so what does it mean right now? And what should people be doing? What do we expect to happen? So maybe I'll kick it back to you, Nichole, and let's talk about the payers.
Yeah, thanks, Glenn. I think generally there's a lot of uncertainty in how states are going to roll out some of these changes. So payers should really focus on a set of strategic actions. And one of those is stepping up as thought partners with states to help shape their strategies around these Medicaid funding cuts and operationalizing these requirements. It's really crucial for payers to be involved at the onset of these discussions, especially around things like the eligibility tracking, the work requirements that we've already talked about, to establish how they can partner with states in the implementation as well as the ongoing operations of them. Payers should also be focusing on scenario and impact modeling to understand how the bill's requirements and the state-specific strategies that their states are taking could impact their membership and market dynamics, and quickly apply those insights to guide their product decisions, their capability investments, and their broader strategy overall. Additionally, down the line, with a sicker population likely to maintain coverage, rate advocacy with states will be essential to ensure payments reflect higher member acuity. And then secondly, really doubling down on proactive member engagement to try to minimize that coverage loss and member churn. Programs that target at-risk members, such as workforce development programs that support members getting jobs, training, rides to interviews, will all be vital. And using AI and predictive analytics to identify members at risk of losing coverage can help with timely interventions and outreach that may help limit some of that loss of coverage for the payer membership. finally, thinking through kind of operational capabilities, the changes from this bill are going to require payers to be operationally agile, and payers need to do a thorough review of the requirements of the bill and their state-specific rollout strategy against their operational capabilities and technology infrastructure to understand the required enhancements and develop an internal roadmap for the rollout of those changes.
No lack of work to do there, Nichole. Shannon, what are we thinking about on your end?
It's a great question. So providers really need to act quickly, and there are probably several steps organizations should consider. They should think about conducting scenario planning. So if it's not already in process, they need to start with their scenario planning, being able to model the delta in revenue under the bill and the anticipated potential shifts in patient volume. It's really going to be essential for organizations to explore how resources can be strategically redirected to commercial payers and assess the possible cost shifts for their organizations. They're going to want to plan for coverage disruptions, preparing for potential coverage disruptions at the point of care. So eligibility verification should happen in real time and is going to have to be conducted more frequently. They're going to want to review and update their workflows and policies for re-verification, copay collections, referrals, really to ensure that they align with the new processes and potential shifts. So some of the questions that organizations will want to consider is, are you collecting information now required for the Medicaid eligibility? Do you have a process for preventing billing Medicaid for non-covered patients or services? Will your charity policies fill the gaps left by the reduced Medicaid coverage? So those are just a few that organizations are going to want to consider. They're also going to want to look at the identity of vulnerable service lines, like identifying service lines or locations where rising uncompensated care may jeopardize financial stability and prioritize efforts to mitigate these risks. And they're really going to want to invest in patient education. Even basic awareness about the benefits can really help reduce financial exposure. So kind of looking forward for providers, it's really about redesigning their care delivery. They need to expect to serve more uninsured and underinsured patients and really start to consider new models, urgent care, telehealth, mobile services if they're not doing that already. Again, like Nichole mentioned, using predictive analytics to identify and flag coverage gaps on the provider side before they happen will be important. They're going to want to consider shifting capital planning towards more outpatient, more digital, and more preventative services. And they're really going to want to evolve their workforce for digital delivery and leaner margins.
It's fascinating, Shannon and Nichole. It seems like there's just a start of continuation of this change that is going to happen and expected to happen. And Phil, on the PLS side, what are you thinking there?
Yeah, definitely a lot to do too. It turns out 1,000-page legislation creates a lot of work across the enterprise. So we're looking at kind of the impact in each part here. From a commercial perspective, definitely companies should be modeling the impact of potential coverage losses on their overall market access, demand, number of prescriptions to expect, and how ultimately that's going to impact revenue, and then what might be done to offset some of those losses. Looking at patient services, a really important area that Pharma focuses on, onboarding and supporting patients on therapy, going to be super important to evaluate how patients currently on therapy might be impacted as they go on and off coverage, lose coverage, and maybe the hospital that they were going to for their oncology infusion goes out of business and they need a new site to get infused, or they now all of a sudden get referred to a new site because their insurance won't work where they're at. A lot of area where Pharma spends a lot of time and investment, and looking at how that might be impacted will be key. A couple areas for bigger capital investment decisions. So certainly this is another push for companies to consider U.S. manufacturing expansion and going along with what we've seen with potential pharma tariffs and some of the onshoring push. And then more broadly, looking at R&D and M&A, this is a chance to reevaluate the orphan drug pipeline strategy in that area, given the new exemption, and overall maybe unlock some opportunities that companies weren't looking at before. So maybe despite not being as directly impacted as payers and providers, definitely a lot to look at for Pharma across the enterprise.
Thanks, team, for the insights here. The one big, beautiful bill is here. It's already reshaping the healthcare as far as how things are covered, paid for, and ultimately what that delivery is going to look like in the U.S. Special thanks to Nichole, Shannon, and Phil for joining us here. We'll be back soon with more on what's next in health. Until then, stay ready, stay informed, and keep moving forward.
This podcast is brought to you by PwC, all rights reserved. PwC refers to the U.S. member firm or one of its subsidiaries or affiliates, and may sometimes refer to the PwC network. Each member firm is a separate legal entity. Please see www.pwc.com/structure for further details. This podcast is for general information purposes only and should not be used as a substitute for consultation with professional advisors.